My name is Dr. Muni Ushiri, a consultant at AGC Tenwek Hospital in Bomet. And today's topic is retinal lasers revisited. Our presenter for today's CME is none other than Dr. Mushai Gashago, a consultant ophthalmologist and retina specialist at the City Eye Hospital, and he is the current chairman of the Vitreoretinal Society of Kenya and exam lead for the College of Ophthalmology of East, Central, and Southern Africa. He is a well-authored in several peer-reviewed scientific papers, both locally and internationally, and is one of the authors of both the Diabetic Retinopathy and Retinopathy of Prematurity Kenyan National Guidelines. So today, outline of our CME will include the presentation from Dr. Gashago. Then we will go to a small or a short presentation by our sponsors who are AbbVie, and then we will go into our Q&A session. And finally, we'll close by giving it back to Dr. Shiko from the OSK panel. So, Karibu, Dr. Mushai Gashago.
Thank you very much. I think I will put up my slides to share. Excellent. So, Dr. Ari, am I audible?
Yes, you are.
Excellent. Thank you. So, my name is Dr. Mushai Gashago, as introduced by Dr. Muni. Thank you, Dr. Muni, for agreeing to moderate this meeting. Absolute pleasure. And so those are my work affiliations. So I'm a consultant ophthalmologist and retina surgeon at City Eye Hospital. And as you can see, I am heavily involved in ophthalmology work, whether it's retina, general ophthalmology, exams, and everything in between. So as regards today's conversation, I have no financial disclosures. So basically, we want to first figure out why the topic, why are we revisiting lasers? And I think the first thing we need to remember is, the importance of lasers in ophthalmology. I think we are one of the practices, lasers were first used in medicine in ophthalmology. So we are the ones who introduced lasers to medicine. And of course, with most conversations these days, most CMEs you'll attend, especially retina-oriented, there's a lot of talk about anti-VEGFs. There's new anti-VEGFs that are always coming out. The anti-VEGFs, of course, have made a huge, made up for huge leaps in ophthalmology in the practice of treatment of diabetic retinopathy, macular edema, and other things. So there's been a lot more conversation around that. And you find that general conversations around lasers and retinal detachment are generally taking a backseat despite the importance to our practice. And that's why we thought, let's bring back lasers, let's talk about them, and just look at a unique perspective to them. So you will remember that laser is actually an acronym. It is not a word, it is an acronym, and it stands for light amplification by stimulated emission of radiation. So basically, when you have atoms going from a higher to a lower energy level, you find that they lose that energy, and that is what is referred to as a spontaneous emission. But if you want to hype that a bit, then you have to stimulate that radiation a bit, and that's what basically lasers are about. So when we now look at the properties of a laser so that it can have the desired effects, you remember this lecture from your lectures in optics, that first it is monochromatic. It emits one wavelength. And therefore, you will find that we define a lot of lasers by their wavelength because of how specific this particular character is. Then the next thing that you have to have is that it is coherent, moving in phase. You could have different lights or even the same light out of phase, but when you have peaks going, as you can see here, this is incoherent light, as you'd get maybe from a torch. But when you have coherent light where the peaks meet the peaks, the troughs meet the troughs, then that is coherent light. So they are all in phase. And then the second thing is that they are polarized. They are traveling in one plane. So you can see in this example here where you have light, which is then polarized, all the lights from the different directions are emitted, and you leave light in a single plane, and that is what we mean by polarized light. The second thing is that it is collimated, moving in one direction. So this is an example of collimation. You've got light in multiple directions, but when you get it moving all in the same direction, then you're heading towards what is laser light. And then eventually it has to be of high energy, giving that intensity. So you have light that has all these properties: monochromatic, silver wavelength, coherent, polarized, collimated, and high energy. Then you have a light that can do a lot more because of its, let's say, unity of purpose. It's in one direction, it's in phase, moving in the same direction, and therefore you get the effects that you get from laser. Now, we know that there are numerous applications of lasers in ophthalmology, and in some, just like in cornea and anterior segment, of course, is all the talk about refractive surgery in form of LASIK or PRK. Then, of course, you have got YAG lasers that we've used for lots of years. Then, of course, in glaucoma, peripheral iridectomies, selective laser trabeculoplasty, cyclophotocoagulation, and then even in retina, now we've got different lasers for macular, for panretinal lasers, and barrage lasers. So we have lots of applications in ophthalmology. But being a retina specialist, I will ignore the rest for today, and we shall talk largely about laser systems in the retina. So there's, just as a way of revision, of course, there's different laser delivery systems. You have, as you can see in the first image, a laser indirect ophthalmoscope. This is a picture taken in the clinic where you have the indirect laser on your head connected to the laser machine, and you deliver the laser. And of course, each of these systems has its pros and cons. Laser indirect, there's a bit of a steep learning curve, but you're able to do laser all the way to the periphery of the laser as you're able to even indent. Then, of course, you've got the slit lamp laser. And in this case, you are able to use it with a coupling lens and deliver pretty good laser, depending on your skill and technique over time. And then, of course, endo laser that we'll do during vitrectomy, where the laser probe is actually in the eye and you laser directly to the laser. So those are some of your basic laser delivery systems. Then, of course, lasers in general use, you've got the green lasers. The most commonly used these days, of course, is the frequency doubled Nd:YAG laser, 2 nanometers. Argon laser, not so much. The gas laser, a bit bulky, so not too many places are using that now. The favored green laser is the frequency doubled laser. And of course, the yellow laser, which is my favorite, the 577, 810. So are the lasers that are in common use currently. Now, we will look at the lasers now in basically retinopathies, largely diabetic retinopathy. Now, we know lasers have been used and been accepted as a standard of treatment for diabetic retinopathy since 1975. We're talking old technology. And that's why these days when we come and we find patients with advanced diabetic retinopathy not being reviewed, not being lasered, coming at the point at which they need vitrectomy for vitreous hemorrhage and tractional retinal detachments, it's rather disappointing because we have had effective and well-established treatment since the 70s. We are talking, this is almost 50, it's now 50 years now since PRP was established to be standard of care for proliferative diabetic retinopathy. And this, of course, came from the diabetic retinopathy study, which was a randomized clinical trial of about 1,758 patients, and showed that laser was effective for proliferative diabetic retinopathy. Now, having proven to be useful for PDR, they wanted to see if it is useful to give it earlier and also take a look at the effects on the macula and also see if aspirin was useful. And this led to the early treatment of diabetic retinopathy study, ETDRS, which is really a landmark study. This was between 1979 to 1985. Again, those are 40 years since we're having these things being established. This was also an RCT, slightly larger with 3711 patients. And this was a study that defined the term that we've used in ophthalmology for a long time, which is CSME, clinically significant macular edema. And although we don't use that term much now since the advent of OCT, but that was a pretty huge step for ophthalmology. And then also showed that lasers were useful even done earlier. And therefore it advocated for earlier laser for cases of high-risk PDR and severe NPDR, and also for focal laser. Previously, they would defer laser treatment, but it was found that early focal laser for DME was also effective. It was found that aspirin was not effective for preventing or treating diabetic retinopathy, and it also established the risks of too much laser. So we've known lasers are effective since 50 years ago, and therefore we need to really remember the key role that these treatments have played. Now, when we look at other indications for lasers, of course, we find that lasers are also useful as PRP in the cases, as we've said, for proliferative diabetic retinopathy and even severe forms of NPDR in central retinal vein occlusions. Branch vascular occlusions, of course, we do sector lasers to avoid neovascularization, especially in ischemic BRVOs. And these are BRVOs of whatever kind, whether related to hypertension, whether related to glaucoma, whether related to Eales disease, which causes an occlusive vasculitis. Whatever the case, you will find that lasers are effective. Then, of course, barrage lasers are also very useful for treating breaks, peripheral degenerations, and even in cases where you really want to do prophylactic treatment against retinal detachment in patients who have had peripheral degenerations and RD in the other eye. Then, of course, macular lasers have also been found to be useful from the ETDRS study. So we have found that you could do grid lasers for diffuse macular edema, focal lasers for, 1 second. All right, it's called parenting. So we have situations. So we've seen that these are now the indications for the macular lasers. Now you have grid lasers for diffuse macular edema, focal laser in cases where focal leaks with exudates around them. We call those succinate exudates, and of course now micropulse lasers. Micropulse lasers are a very interesting area of practice because these are lasers that are non-scarring and you can laser even the fovea. And they're useful. And we've done them at CTI for possibly the last 6 years. And I think that would be a topic for discussion for another day. We have found them to be quite useful in the treatment of macular edema, especially DME, and even in cases of central serous chorioretinopathy. So when we talk about lasers, a lot of hype and talk goes around what happens if you do too much laser. If you ask anybody what are the complications of laser, most of the time they will zero in on the complications of too much laser. And we know them well and can rattle them off very quickly. But so let us start with that. Then we shall move on to other complications, because that's what I wanted us to highlight on today, really. So when we do too much laser, this is where someone does maybe too high energy being delivered in with a laser, or or too many spots or too many spots too close together, then that's what we're saying is too much laser. When you do a burn, there's a kind of whitening you want to see on the retina. You don't need to blanch where it's paper white. That way you know you're doing too much laser. So when you do too heavy laser, first patient will complain of severe eye pain. If you're doing it under a block, as we do in some of the cases of indirect laser, then the patient might not complain of pain there and then, but they will complain of it later. But you then have severe eye pain in cases of too high laser, especially without local anesthetic. Then, of course, macular edema coming from because of the result of too much laser causing too much inflammation, and this then can result in macular edema. Especially in patients who already have macular edema, you could find a worsening of the macular edema. Then also due to that inflammatory effect and even just the laser effect, some patients report with increased intraocular pressure following laser. Now, heavy PRP, there are people who are very aggressive with their lasers. And therefore, this is the kind of picture you will get with too heavy a PRP. This laser, you can see extreme bands that have come very close to the macula, very close to the disc. And these scars, once you do them, remember after initial PRP, this scar might have been here, but in some cases, the scars expand. So you have to think about that. So here you can see severe chororetinal atrophy following a very heavy barrage laser. And really, you're just seeing through to the choroidal vessels and even the sclera. So you have increased blind spots, severe visual field defects. And because your peripheral retina is largely responsible for your night vision, then patients report poor night vision. And these patients could really complain of this particular effect when they need to walk out in dim lighting. So heavy PRP, like in this case, can result in those side effects. And those ones are well known. Now, the one that most people talk about is choroidal detachment. And a lot of people know that heavy laser can also lead to choroidal detachment because of inflammation and accumulation of suprachoroidal fluid. So in this case, you can see a patient who had choroidal detachment in the periphery following heavy PRP. Then, of course, you have now the complications of laser in the wrong place. All right, you have had now too much laser. But what about doing laser in the wrong place? So, of course, the biggest complication would be inadvertent laser to the fovea. That is really just the one thing you must avoid. And so whenever I am teaching laser, I just have one rule: do not place a spot on the macula. You either get 0% or 100% when learning laser. 100% is if you even manage to place just one spot, and that one spot is not on the fovea. You get 100%. If you place 1,000 spots in the right place, you still get 100%. So you just have to place laser anywhere other than the macula. And of course, you get 0 if you place it on the fovea. There's nothing in between. If you can place one spot in the right place that is not the fovea, then you can place 2 spots, you can place 3 spots, and you can place 1,000 spots. So my main point here is do not laser the macula. So you can see this is a case where someone was doing PRP, they were doing it very well, and I think they got carried away, kept getting closer to the macula, and you can see, bam, laser spot on the macula, laser spot, laser spot. This was right at the fovea. So this is really the kind of case you want to avoid. I have seen cases where the laser, the patient did, the doctor did a good PRP, and instead of leaving the macula out, they left the nasal macula out. You know, the images are inverted and upside down when you're doing a PRP. So they kind of mistook the macula for the nasal retina. And the macula is lasered perfectly, and the nasal retina was left free. And that was really just like a really terrible complication. And you're really you're conflicted what to tell the patient at this point, because they come telling you how they were lasered and now they're not seeing properly. And you look at the macula, it's got a nice PRP over it. So this one, you can see it wasn't a complete PRP of the macula, but you can see they got carried away and got too close to the macula. And the problem with these scars, they expand. So this particular case over time developed an ERM here, and eventually a macular hole formed where this laser spot was placed. So you can see over time, the complications can get worse. So that is really the I guess let's call it the cardinal sin of PRP, lasering the fovea. Do not laser the fovea, please. Now, second thing also is grid lasers, because we do a lot of grid lasers as well for macular edema. Even with anti-VEGFs, there's still times where we do a lot of focal lasers to microaneurysms that are leaking, and also grid lasers, which, in patients who are poorly responsive to anti-VEGF treatments. And so if you do too heavy a grid laser, you'll find that with time, these scars also tend to expand. And therefore, you need to keep grid lasers very faint and still a safe distance away from the macula in case of scar expansion. Now, finally, you can also have strong laser to a vessel. And I've seen this happen where laser to a vessel and you actually get bleeding instantly. Even very heavy laser to the retina can cause bleeding from the choroid. So you can get vitreous hemorrhage following laser if your laser powers are too high. So whenever you're titrating power, start low, go high. Especially for younger patients with clear lenses, you often don't need that higher power. At 150 powers, you already find blanching. And in some patients with cataracts and those, you find you're going to 700, 800. So always start low and work your way up to avoid that inadvertent strong burn to the laser. Now, second thing is to avoid that also, if you have someone controlling the power for you, have them shout back everything they enter. So if I say power 200, duration 200, let them set it and repeat it to you. Many times I even take a glance at the screen to make sure that is what has been entered, because you might have, a power of, you wanted maybe a duration of 0.2 and they put 2, and you find that's a huge difference when it comes to lasers, right? So that's how you can avoid that. So now, those are the complications of too much laser and laser at the wrong place. Now, what I have found to be the biggest complication of all is too little laser. And that is why I even brought this topic today, because I'll see a lot of patients who have potentially had laser done in other places. And so you find that the lasers are inadequate and you're having to laser them again. So the complication of too little laser is what I see actually most of. As I tell you, I don't think I've ever seen a choroidal effusion from laser, but the complications of too little laser, that I see frequently. So this is a case we saw even at the clinic recently of a patient who was now having too little laser that was too far away from the arcades. So you get neovascularization and membranes forming towards the macula, because that's the retina that has been left. It's been left and is still producing adequate amounts of VEGF, and therefore still stimulating neovascularization. And these vessels will then tend to grow away from the laser and towards the macula, which is not yet lasered. And this was such a typical case. You can see this pale disc here. Laser has been done, but you can see it's towards the temporal side. You can't even see the laser on this side. Superiorly, you can't even see the laser there. So it's too far away from the arcades. And even the spacing is rather large. So you can see these new vessels forming right over the macula. This is the macula. You can see these huge neovascular front vitreous hemorrhages forming there. And this was because of laser too far away. So the vessels decide to grow over the macula. And this is a real life patient we saw. And now you wonder now, where do you now start adding your PRP in this case? So these are the kind of cases that you now have to kind of start on anti-VEGFs to have those vessels regress and then later top up your laser so that you don't have a recurrence of the same. The other complication then you get, this is another one now I found also, too much, the laser is a little faint and too far away from the arcades. You can see there's no laser you see here, yet you see very sclerosed vessels. And you can see the neovascularization again runs away from the laser towards the macula, which is the last place you want it. So you can see huge fibrovascular membranes right over the macula. Now, this is another case of too little laser. Now, in that case, people are generally afraid of the macula and therefore stay too far away from the macula. So they stay too far away from the arcades, too far away from the disc, too far away from the temporal side of the macula, and therefore you start getting neovascularization over the macula. But in some cases, people do a good posterior pole laser, but because of one, either skill, you're not skilled enough to go far enough towards the periphery, whether it's on slit lamp, by asking the patient to look up, down, left, right, or using a 3-mirror lens to go really peripheral, or indenting with your indirect laser, then you don't do a peripheral enough laser. Or in a case where a patient has had a vitreous hemorrhage, like in this case, patient has a vitreous hemorrhage, and therefore this area was not lasered. And when that area is not lasered, you find that later the VH might clear, but you don't top up the laser. So this area is left bare. And in some cases, you now start getting fibrovascular proliferation, neovascularization happening very anterior to the retina. Now, if all the time you're looking at your patient with a 90D, you may never see these anterior fibrovascular fronts. You might only see them when you see with an indirect or with indentation. And so a lot of people fail to see these anterior fibrovascular proliferation. And so what happens? You believe your patient is adequately lasered, but they keep having these recurrent vitreous hemorrhages because those things are constantly leaking, they're being pulled on by the vitreous, they bleed. So you have recurrent hemorrhages and you're not quite sure what is causing them until the day you look peripheral enough and you see those membranes. And these you can therefore now treat either later during a vitrectomy with endolaser, or some people have done cryotherapy to ensure that the peripheral retina is coagulated, or laser with indentation when there's less hemorrhage. So you have ways to treat it, but you have to have identified it. And this was a case I saw of a patient who was actually a single eye patient and was getting recurrent vitreous hemorrhages. And eventually we figured out he was having anterior fibrovascular proliferation, and his VHs were always so dense we really could never get a chance to laser them. So, and he was afraid of getting that eye vitrected, so to speak, because of having lost the previous eye. Then he was only to the single eye, so we settled for an anterior cryotherapy. So we did an anterior cryo, and that actually settled that eye eventually. So that is our solution. But it came because his anterior retina had not been adequately lasered. So you might have too little laser at the posterior pole or too little laser anteriorly for whatever reason. All right. Now, the other thing that is common is a term I coined called the donut PRP. And this is a case where people are generally afraid of coming too close to the disc or too close to the arcades, so they stay far away from the macula, stay away from the disc, stay away from the arcades. So this area is bare. And then anteriorly, they do not go there either especially because of a lack of skill. And you find this happens in a lot of early lasers, like people who are learning laser, maybe during your residency or fresh out of med school or of ophthalmology, you find your lasers are not adequate towards the posterior pole or anteriorly. So we call that a donut PRP because we look at the laser pattern, it looks like a donut. And so in this kind of case, you then put the patient at risk of posterior fibrovascular proliferation and anterior fibrovascular proliferation, as we just discussed in the two previous cases. So you get both of those things happening, and it can be quite detrimental because eventually you get a lot of membranes forming in this area. Those membranes now start forming a napkin ring or posterior polar retinal detachment. And around the macula is where you don't want any drama. And now this is where you're really get into it, because you've got a lot of VEGF being produced in the periphery still, and you've got bare areas here that allow for proliferation of vessels and membranes, and therefore it tends to complicate in the worst way. And therefore you find you're doing very posterior pole kind of vitrectomies for macular detachments along the arcades, and you're having to peel a lot of posterior membranes, and it makes for quite complicated surgery. And the thing is, all these patients you've said with inadequate laser, once you do the laser, the patients are so happy. They are confident. Laser is complete. I am treated. You find many of them even get lost to follow up because they know they have been treated. And therefore, these complications then creep up on them and they come back laser. So you can find, this is a case I actually did just last week on Tuesday. It's a patient who presented with a tractional knee.
Apologies for that. Let me look for Dr. Mushai Gashago. Be patient with us. Oh, he's back.
Yeah, am I audible? I think the line dropped. Can you hear me now?
Doctor, you're
Dr. Munyi?
audible. You can continue.
I'm back? Okay.
Yeah.
Yeah, it dropped for some reason, yeah. So this is a case I was saying we did last week on Tuesday. A patient who came with a nasal tractional retinal detachment with lots of membranes. And when we looked, of course, you could see there was good laser. So when we went in for the vitrectomy, there was this big, huge membrane that we managed to peel gently. And when it got off, we could find a lot of retinal folds under that membrane. And once we were able to flatten that retina, we actually found that there was not a single laser mark in this particular quadrant. And this just shows the evidence of, an inadequate laser. For some reason, this patient had been lasered, and for some reason, this nasal retina did not receive a single spot of laser. And I don't know why. Maybe there had been a vitreous hemorrhage that covered it, or maybe it was just skipped. But we found that all those complications that we were now getting, a detachment and membranes that we had to peel, was because that particular segment of the retina was not lasered. The rest of the retina that had been lasered was nicely attached, and there was no bleeding. So you find this just tells us more about that inadequate laser causing long-term complications that you might have to later revisit surgically. All right. So basically, you also have to remember that lasers take time to work. Remember when you're doing a PRP, remember first tell the patient lasers do not improve your vision because they'll come to you the next, after a short while and say, daktari, bado sioni vizuri zaidi. And you have to remind them that the laser, first and foremost, you're not doing it to improve their vision. You're doing it to reduce the risk of bleeding and detachment and other long-term complications of diabetic retinopathy. Now, also that it is reducing the risk. It is not eliminating it. A lot of patients will still get vitreous hemorrhage even after doing a laser, might even get retinal detachment if the laser is not adequate. So you have to tell them that so that the day they bleed, they're not so surprised. Then remember also laser takes time. We're talking about by the time the laser marks start to scar is about 2 weeks. By the time it is properly scarred and VEGF levels in the eye have dropped, it takes a minimum of 6 weeks. Within those 6 weeks, the eye can still bleed. All right, so yeah, we're just concluding. So the last thing I was going to say is that in terms of combining with anti-VEGF, because as we've said, lasers take time to work, and therefore we find in cases of active PDR or neovascularization following a central vein occlusion or branch vein occlusion, that you might do the laser and the patient still bleeds. So we found a good solution often is to combine the laser with an anti-VEGF of whichever kind you choose. So that you give the anti-VEGF, anti-VEGFs work quickly to kill neovascularization. In 3-4 days, you actually have those new vessels shrinking and therefore reduce the risk of bleeding. But you know that anti-VEGFs will only be effective for possibly a month and maybe slightly more. But at that point in time, the laser effect between week 2 to 6 is kicking in. So for active cases where you have a lot of neovascularization or even early vitreous hemorrhage, I prefer to combine my laser with an anti-VEGF. Anti-VEGF works quickly, and PRP then works for a long time. So those are just some of the tips and some of the conversations you can have with your patient about laser or laser with combined anti-VEGF injections. So basically, in conclusion, we still have to remember that lasers are still essential in retina practice. for all sorts of vascular complications, including diabetic retinopathy and maculopathies, and recognize that too little laser can be a big problem. And that's a point I wanted to bring out today, because the complications of excessive laser, I think we all know, but I just wanted to present to you some of the cases that I have seen and some of the complications I've seen over time of patients who have not been adequately lasered and therefore then present with longer term complications that we end up having to manage. So thank you very much.
Asante sana, Dr. Mushai Gashagu, for that presentation. I know all of us have had contact and know about laser, and thank you for taking us back to the old days. For me, personally, the key highlight has been too little laser, the effects of too little laser. And this is a big highlight, as most of us have laser machines in our facilities. And I would encourage everybody to take a bit of knowledge from that and do adequate laser so that we get to have less patients getting into the vitrectomy space. Next, we're just about to get into our question and answer session. But before we do that, I'd like to invite the AbbVie team give us their presentation. And as the AbbVie team does that, I would request anybody who has a question to post it online, and I will be giving the questions to Dr. Mushai once the AbbVie presentation is over. AbbVie team, karibuni sana.
So, good evening. Hello, can you see me?
Good evening. Yes, we can see you, John. Yes.
Okay, thank you.
And you're audible.
So good, yeah. Good evening, ladies and gentlemen. Good evening, my doctors. So today we have a presentation, and it's going to be done by our MSL, Dr. Ruba. So we want to welcome Dr. Ruba to share the slides. Thank you.
Good evening, esteemed doctors. This is me, Ruba El Basha, joining you from AbbVie. Today, I will be giving a briefing about dexamethasone intravitreal implant and their indications and patients' profile for the dexamethasone intravitreal implants. Thank you for giving me that opportunity. So we'll be starting with the main indications. The dexamethasone is indicated for the diabetic macular edema. It is also indicated for the treatment of macular edema following branch retinal vein occlusion or central retinal vein occlusion. And it is also indicated for the treatment of non-infectious uveitis that are affecting the posterior segment of the eye. We know also that, excuse me, okay. We know that the dexamethasone acts fast and lasts for up to 6 months in diabetic macular edema patients. It suppresses the inflammation by inhibiting a number of components of the inflammatory response. Now, the eligible patients for dexamethasone intravitreal implants are overburdened patients, patients who has biomarkers that help predict the treatment response, insufficient responders for at least 3 AVF injections, and pseudophakic patients who had previous cataract surgery, which means that there is no need to consider the lens status, and patients with previous vascular events, mainly patients who suffer from hypertension and previous myocardial infection. Treatment should be tailored to individual needs, and results between patients vary. When we talk about overburdened patients, we talk about patients who feel overwhelmed with many medical appointments, notably patients who suffer from diabetes. They are likely to have other comorbidities as well, and they may have healthcare appointments on average every 10 days, around 10 days, which can impact their adherence to other treatments. Patients also have mobility constraints, and patients who, due to their work, they work full-time and they feel unable or unwilling to take time off work for regular treatments. Then OCT biomarkers can help predict treatment response to dexamethasone intravitreal implant. We talk mainly about the SRF, the intact inner segment and outer segment, and patients with no hyperreflective foci. So these are patients who most probably will be responding to the treatment with dexamethasone. Dexamethasone intravitreal implant is also recommended to insufficient responders, responders who are treated with anti-VEGF. So these patients, most of the time, if they do not respond to three treatments, they are unlikely to respond to subsequent treatments, and that was proven by several studies. So here, for example, in a randomized clinical trial comprising 660 patients comparing their anti-VEGF agents for diabetic macular edema treatment, we noticed that there were no statistically significant functional differences between aflibercept and ranibizumab at 2 years for patients with better or worse visual acuity at baseline. So in summary, the dexamethasone intravitreal implant is a long-lasting treatment option versus anti-VEGFs for your suitable diabetic macular edema patients who are either overburdened patients or patients with biomarkers with OCT evidence for being responders, patients who are insufficient responders to regular treatments, and pseudophakic patients, and patients with previous cardiovascular events. So that was all. I've been told that I have a very short time for presentation, and I wanted to respect the time frame as much as possible. Thank you.
Thank you so much for your presentation, and we'd also like to thank the AVI team for sponsoring this CME. We will jump right into questions, and I will start with the first questions for Dr. Mushai Gashago. First question is from Jean Jr. He says, thank you very much for the presentation, very interesting. When doing laser, is there a minimum number of spots that one should aim for?
Excellent. I think maybe AbbVie team can stop sharing their slides.
Yes, I will stop sharing my slides. Okay. Done.
Good. All right. Thank you, AbbVie team, for that excellent presentation, and thank you for reminding us about intravitreal dexamethasone. We've used it and we love it. So I think to answer Jean's question in terms of number of spots, I think number of spots is one of the things that has over time been misunderstood, because I've had people say things like, okay, 500 spots per session. I'm not sure who said, or maximum spots 1,000, or maximum laser power 700. Those are kind of statements I've had. But basically, when you're doing laser fasting, is the strength of your blanch. Know about how much it should blanch. Not paper white, not too faint, somewhere in between. And there's lots of books and references you can see for what kind of laser power you're aiming for online, so that then you don't have in your head, I've got maximum power of 700. If a patient has a dense vitreous hemorrhage, has a cataract, you're going to require higher laser. So you let your blanching guide you. Even if you get to 1,000, it can't be too much if it's not blanching. So let the blanch guide you. Now, in terms of number, for me, I don't even look at the counter. I do lasers, and then I look at my retina, I relook it once I am done, and if I'm happy with the spread of spots, they have no skip areas, I've gone peripheral enough, then I look at the machine count just to record, to document. Because you might be so fixated on the number that you're aiming for a minimum of 5. I mean, if you have half VH and you can only laser half the laser, then you might only be able to put 300 or 400 spots, and that's it. As long as you see you have adequate coverage, that's when you know you have reached your minimum or maximum. So once I look and I'm done, then I look at the machine just to record. I did 1,000 spots, I did 800 spots, and I'm happy. So I don't set in your mind a minimum, don't set in your mind a maximum. Look at the coverage and be happy with that. Because even of the, let's say you say I've done 1,000 spots, how many of those spots are effective? You might have maybe 50 of those were you trying to titrate. Another 100 might not have taken very well and therefore really didn't blanch anything. So you don't know how many were effective, how many were not, how many were test spots. So just have adequate coverage, write the number of spots for matter of documentation. Yeah, don't be so, some people look at the machine and the minute it reaches a certain number, they stop. There's no rule on numbers really. Just have a good coverage and be happy with it and then record that. Yeah.
Thank you for that, Dr. Jean Junior, I hope you have your answer right there. Next is a statement from Dr. Chosky. He says, great presentation, Dr. Gashago. Thumbs up, having used laser for over 25 years. I feel close follow-up is crucial. Then Dr. Jaffaji says, great and concise presentation, Daktari, well done. We have Dr. Walia saying, great presentation, Daktari, and thanks for reminding us of the importance of laser in eye work. Then we have Joyce Awum. She says, thank you, great presentation with very important highlights. Please, following your experience, how many sessions do you recommend doing laser in a patient to be complete? And the next question is also regarding the combination with anti-VEGF with laser, after how long do you give the intravitreal injections? Thank you.
So there's a question higher up I saw posted by Dr. Wendy Njoya asking about role of laser in severe non-proliferative diabetic retinopathy. That was just before Jean's question. So I think to answer that, yes. So we generally do, from the DRS, it indicated laser for, proliferative diabetic retinopathy. But the ETA DRS showed that you could do it even for just high-risk PDR and also for cases of severe NPDR, especially in our setup where follow-up generally tends to be poor. Once you get a patient with severe NPDR, that is usually for all 4 quadrants of retinal hemorrhages, more than 2 quadrants with venous beading, more than 2 ERMAs, and then also cottonwool spots. For me, I use cottonwool spots also as a major guide because cottonwool spots are a sign of ischemia. If you count 7 or 8 cottonwool spots, laser that patient. The ischemia is there, the neovascularization is coming. So those are cases of severe NPDR. And in our setup where follow-up is not guaranteed, access to ophthalmologists is limited, and even as a general guideline, you can laser those patients to avoid them going on to proliferative retinopathy and therefore avoiding now those later complications. So there is role for laser in that particular setting. Now, in terms of number of sessions, now the biggest fear, of course, has been choroidal effusion. As I told you, people know a lot of the complications of too much laser. Now, as I told you, honestly, I have not seen a single case of choroidal effusion following PRP. I am yet to see it. So it might be a thing, and previously with the heavier lasers, previously people used xenon arc lasers, used more of the diode lasers. Those are red lasers which penetrated deep into the choroid and had a lot higher risk of choroidal effusions. The lasers we're using now, largely green lasers, FDR lasers, and yellow lasers. So for us, largely 90% of my lasers, I do the 577 nanometer laser, and the other laser we have and use most commonly is also the green laser. We also have a diode laser. I find it better for cases of dense cataract and vitreous hemorrhage, but I don't use it often. So with the yellow and green, I generally do, and at CTI generally we do 1 laser session, full PRP, and generally that will be averaging about 1,000 spots, depending on the patient. It might be anywhere from 800 to 1,200, sometimes 1,400, if there are not too many effective spots. So generally, I do my lasers in 1 session. There's places where they believe in splitting them, and it's okay if that is your practice. And some people will say do half first, and usually they'll say aim for the lower half, the inferior retina, because if a vitreous hemorrhage happens between your first and second laser, then it will be difficult to laser the inferior laser. So some people will do a half laser, inferior, then book the patient for a second laser, superior laser, for fear of complications of too much laser. So that is a possibility you can approach. There are patients who have told me they have been booked for 5 laser sessions, and for me that sometimes perplexes me, because I don't see a situation where you need 5 laser sessions, other than in a case where a patient maybe has a vitreous hemorrhage and you're taking a very conservative approach for whatever reason, and you don't want to do a vitrectomy, so that as the hemorrhage is clearing, then you're topping up the laser. Now, I can see how that could end up in 5 sessions, but a planned laser 5 sessions from day one without significant vitreous hemorrhage, I think that is too many sessions. So you can actually do it in 1. You could do it possibly in 2, inferior then superior, or progressively adding if that is necessary as VH clears up. So you could do it in 1, you could do it in 2, and I'd say that's still a reasonable settlement. But anything other than that is under special circumstance where you're doing it because of a barrier to that laser. So that is what I'd have to say about number of sessions. Then in terms of combining laser with PRP, I do it at the same time. Do the PRP, and once I am done, prepare now the patient for injection. And see, many times I'm doing an indirect laser, patient is already blocked, so they don't even feel the injection. So I do them in the same sitting, do the PRP, do the anti-VEGF, and then give them a review after 6 weeks most of the time, because by then the laser has, really cooked in. So I'd say that's what I have to say about combining. In cases where there's bleeding that you think is not too much, but you'd like it to clear so that you get a bit more laser in, you could do an anti-VEGF. Then maybe after a month when the vitreous hemorrhage is clear, then you can do a better PRP. So in those settings, you do an anti-VEGF, give it a little time, let the blood clear, but you're planning to do the PRP. Because remember, the PRP is a treatment. I've had patients who are chronic anti-VEGFs for vitreous hemorrhage, not DME, for vitreous hemorrhage. And I think that's not good practice, although we've had the protocol S of the DRCnet, which showed that ranibizumab can be used for the treatment of PDR. But when you think about the cost of monthly ranibizumab, in most places in Kenya, that's about 65,000 shillings every month to whenever, that is 1 PRP session. I just don't find that makes economic sense in our setting. So it can be used and has been validated for the same, but the treatment really for PDR in our setting and in most places is still PRP. I've had patients even coming from the US, PDR with vitreous hemorrhage, and they're just getting injections, whereas a lot of these patients could benefit from laser, some even from vitrectomy. They've had to postpone flights back to America for us to do vitrectomy. So you have that kind of a setting where just remembering that laser is the treatment. The anti-VEGF in the case of VH is a supportive treatment and not the final treatment as in cases of DME. So I think that's what I'd have to say about that. I don't know if any of the other retina people have comments. I think some of them are on the call. Dr. Jaffaji et al.
Hello, everyone. Mushai, would you like me to comment?
Yeah, sure.
Asante sana. I just written there as a comment that regarding choroidals, actually, I see a lot of choroidals happening when we do lasers. Yeah. And if you break it into a couple of sessions for patients, I use it to my advantage, actually. You'll find shallow choroidals in the periphery. So what I do is I don't indent these patients in the first round. I put in my PRP, I wait for the choroidals to come, and then I laser the peripherals where it is automatically indented. Yeah. Now,
okay. Oh, that's a point. Okay, excellent.
Right.
That's an interesting point of view. Thank you. I knew I'd enjoy your comment.
Now, Musha, you have told us everything about lasering. I wanted to talk about when not to laser.
Yeah.
Okay, so for the general ophthalmologists, what I'd say is if you see traction, just avoid lasering. Even if you see a little bit of traction, refer those cases. Because even at our level, yeah, judging that traction is not easy. Which traction do you leave and laser, and which traction do you go in and do a vitrectomy. So by and large, if you see traction, just refer that case, yeah, as soon as possible. For some of them, you go around, you start lasering, and you actually worsen things. Then, if a retina is already detached, don't try to laser around it and try to surround it and try to. It is detached. Most likely to need a vitrectomy. Then there are other situations where even in diabetics, other than the hereditary, you get this retinoschisis, you get splitting of the retina. Yeah, and if that has happened, don't try to laser those areas. And then in edemas, yeah, macular edemas due to CRVO, generally those ones will not respond to lasers, yeah, central lasers. That one you have to hit them with anti-VEGFs or steroids, yeah, and implants for that matter. So those ones very conservative, and don't go around lasering that. Then there is one other laser where you have to be careful is lasering when not indicated, where you've got a burnt out retinopathy. These guys, they come, you see sclerosed vessels, a quiet looking retina, attraction which is there, but it is really not doing anything. Kitu imeisha. Don't bother lasering that. Yeah, it has already sorted itself out. And then one important point which you mentioned, Mushai, and which should be driven home is lasering that periphery. This is something the late Dr. Kibata actually taught me, and I've carried it in all my lasers. Laser that periphery, because you live it, you laser everything else, and these guys then come with neovascular glaucoma, because that periphery of yours seems to be secreting enough VEGFs, which go ahead and cause anterior segment neovascularization. So please laser the periphery well. And too late a laser, like in it's very aggressive PDR. Yeah, that one you want to put in your anti-VEGFs first, and then go ahead and laser. Otherwise, it messes and it causes actually tractions and worsens it. And one other thing that we got to remember is diabetic retinopathy is a disease of the posterior pole. Yeah, it is not an anterior disease. Yeah, so that posterior area which you've hammered it home, Daktari. So that one, laser it. Just keep it about 1 to 2 disc diameters from the arcades, yeah, from the disc. Everything else goes. Those are the few comments I had, Daktari. Thank you.
Thank you, Dr. Jafferji.
I'll ask Dr. Shah to mute himself. Dr. Shah? Dr. Kamar Shah, you can mute yourself, please. Dr.
Oh, nothing.
Apologies for missing your question.
Sorry, nothing
I owe
from me.
you one for that. I'll go to the other comments. We have Dr. Terry Chege say great presentation, Dr. Muchai. Dr. Joseph Nyamori says, thanks, Dr. Gatago, for the great talk and highlight. Dr. Pranav Chada says, very informative presentation. Dr. Patrick Naga says, great presentation, Mushai. Then Alice Oma says, thank you, Dr. Mushai, great presentation. And Dr. Jafferji, thank you so much for expounding on your comment. I was just about to ask you to expound on it. And we have learned a lot from you, Dr. Jafferji. Then Frank Okada said, great presentation. Mwalimu, any cautions you take in single eye when you're doing the laser?
Good. Yeah, so Frank has asked about the single eyes, and I see further down he's asked about membranes causing traction. So I think in terms of single eyes, I mean, I think the rules still apply. You have the patients being apprehensive, especially if the other eye had been treated and they worry about it. So I think it's up to you to kind of have a conversation with them. But I mean, if an eye meets criteria for PRP, I think you can do it. Extra precautions, you may, in this case, maybe split the sessions. If you want to expose them less to the risk of choroidal infusions, you may. But again, just doing an adequate PRP will reduce the risk later of vitreous hemorrhage and retinal detachments. When it comes to the membranes, I think Dr. Jaffaji has covered that adequately. When you find traction on the retina, if you have someone you can refer to close by in the form of a retina specialist, you could refer. If you are the only person and must deliver that laser, stay away from membranes. Basically, you're advised to stay at least 2 disc diameters away from membranes, because once you do your laser, posterior hyaloid starts to contract, membranes start to contract, and your laser could actually do the patient more harm in form of causing vitreous hemorrhage from, PVD or tractional retinal detachment. So if you're the only person who's able to do that laser, do it, but stay at least 2 disc diameters away from the membranes, away from the disc, and away from the arcades. That way you do a safe enough PRP and stabilize that eye, and then you can always refer them then for further assessment that they can access retina specialist later.
Awesome. I think we have answered all the questions that had been posted on the chat, and I'd like to once again thank you, Dr. Mushai Gashago, for the brilliant and mind-blowing discussion on lasers. They seem such a very trivial thing, but now that you have explained it to us once more, I know we will do the best that we can to ensure patients don't go blind. I would also want to thank again the AbbVie team for sponsoring the CME, and everybody who has come to today's CME, thank you so much. And also for the question and the comments, we appreciate what you've done. This is a very interactive and good learning session. Now we will go to the AOBs.
Yeah, and I think I'll also say thank you to OSK team for asking me to make this presentation, Dr. Wanjiko specifically, and the rest of the team. Thank you, Muni, for hosting us very well.
Thank you.
And thank you all for your kind attention, for taking time to engage with the topic, and even for the retina referrals that we get. We're grateful, and of course, we are all working to give people better lives and better sight. So let's keep working as a team.
Thank you very much, Dr. I will now hand over the session back to Dr. Wanjiko, who said she hasn't met me, but hopefully I'll get to meet her one of these days. Dr. Wanjiko?
Thank you very much for that great and informative talk. Thank you, Dr. Mushai, for agreeing on short notice to make the presentation. Reminder to us to pick a slot for presentation. The available slots are pinned in the notice board, so the council to pay for the Zoom, these Zoom meetings that we're able to enjoy and get our CPD points. So have a great week ahead, and our next CME is in 2 weeks' time. We will post it the notice board. Have a great evening, and thank you both very much. Kwaherini.